Hello, everybody. I'm Jeremy Johnson, and as a reminder, I'm one of the clinical pharmacists that works over in our internal medicine clinic. It's been a long time since I've gotten to speak in front of you all, and so I'm glad to be back. For those of you that don't know me, I probably need to reintroduce myself a little bit. I want to go ahead and start sharing my slides here so we can get rolling with things. But again, I am one of our clinical pharmacists. I'm actually faculty with Southwestern College of Pharmacy. You might see me with my pharmacy students or pharmacy residents around the clinic a lot. My main role over at our internal medicine clinic is I have a diabetes education and management service. I'm glad to work with your patients to help with you and your patients to help get their diabetes under good control, provide education for the patients to where they understand their disease state and what's really going on with it, to where they can buy in and be more adherent. Just want to help work with you all to help achieve all the different ADA standards and goals and such for our patients. So anyway, as a reminder, I'm still around. I used to have a cubicle right there next to all the residents in clinic, but I've been moved to a different office upstairs. But I'm still here. I'm still here seeing our patients. A little bit of a hiatus right now with COVID-19, but looking forward to working with you and your patients as we kind of work through this time. So today I am going to be talking about insulin adjusting. We're going to look at fixed dose pattern management for the most part. Basically going to review a lot of our insulin products that we have available to us out there, talk about insulin curves and how to adjust insulin doses based on patterns that are uncontrolled still at this time. It's a pretty basic review of things, but I've talked to some of our residents at times, and they felt like this would be something that was good to share with everyone else. So sometimes a good review of the basics can be a pretty important reminder of some things. So with fixed dose pattern management, you can do a fixed dose pattern management approach with anybody with diabetes, with type 1 or type 2 diabetes, but primarily I would think of using that in type 2 diabetes. Type 1s often would do better with a flexible dosing schedule where you have like correction factors and insulin to carb ratios and figure out what specific dose of insulin that patient would need per meal. This is a little different. A lot of time, type 2 patients don't really require that kind of precision, and a fixed dose pattern management approach to their management can really simplify things. It works very well. A type 1 who is not able to do a flexible dosing regimen could still do this. It won't be as precise. It has a few more risks, but it may actually work out better than them not being able to handle the more complex method of doing it. So this will be an approach that would probably most commonly use in our type 2 patients. Let's go ahead and start by reviewing all of our insulin products. So for starters, we've got a lot of different insulins out there. When I think of all of them, big picture, I think that the main differences between them are going to be how quickly does it start working and how long is it going to last. And I guess you could also throw in there whether it peaks or not. So how quickly does it start working? How long is it going to last? Does it peak or does it not? So I think thinking about it that way, we can really break all of our insulins down to 4 different groups: rapid, short, intermediate acting, or long acting. So let's take a look at the insulins in each of these groups. So start off with rapid. We've got Humalog or Lispro, whichever we want to pronounce it. It's available as a U100 or U200 product. Most of our insulins are U100 products, but this is one that comes in a concentrated version as U200. You dose them the same way. The device takes the concentration into consideration. So those are used as a 1-to-1 ratio to each other. Admelog is another product that is Lispro. It's the same as Humalog. It's a fairly newer product. We're all familiar with Humalog. Admelog we may not have heard of. You should think of Admelog as generic Humalog. we can't necessarily technically say that it is, but it is Lispro U100 insulin. Basically, Humalog came off patent, and another company is able to now make Lispro, but they have to give it its own sort of brand name. So that name is Admelog. Pharmacists cannot substitute Admelog for Humalog. So if you write a prescription for Humalog, they have to fill it as Humalog. If you want Admelog, you have to actually write the prescription for Admelog. That rule might change one of these days. I've heard that the FDA is looking into making that a possibility, but right now it's not. So if an insurance wants Admelog instead of Humalog for cost issues, you have to actually write the prescription for Admelog. So keep that in mind. We also have Novolog, or Aspart insulin. Pretty familiar with that one. Fiasp is a newer product, been around for 2 or 3 or so years now. And really, you should just think of it as faster Aspart. It's Aspart, but it works even more quickly than typical Aspart does. Not going to spend a lot of time talking about it. Not a lot of real special roles I want to point out for it. It's just going to be very similar to Aspart, but works even quicker. Apidra is our other rapid-acting glulisine insulin. You could really think of using Humalog, Novolog, or Apidra interchangeably. They all work basically the same way. They're all rapid, and it really just comes down to coverage, which one you would select for the most part. All right, let's look at the next group is our short-acting products. This is really just one product. It's regular insulin. Regular insulin, U100, we might just call it R. The brand names are Humulin R or Novolin R. Those are just two companies. Humulin, Novolin. It's like Kleenex and Puffs. It's the exact same product, just made by two different companies. What's important to point out is not the word Humulin or Novolin, but the R. So they're also going to make N or NPH that we'll see in just a second. You've got Humulin R, Humulin N, and Humulin 7030 insulins. So you want to make sure when you're talking about these insulins, especially when you're writing notes in a chart, that you point out what kind of Humulin you're talking about, the R, the N, or the 7030. Or if it's Novolin, same concept, R, N, or 7030. That's more important than the word Novolin or Humulin. But I've seen a lot of people document in notes, increase their Novolin today to this many units. And I've got to wonder, are they talking about the R or the N? So that the R and the N is the important thing. So make sure you remember to always mention that part. All right, so our short acting, there we go, it's regular insulin. Our intermediate acting product, we really just have this one, is NPH. We might also just call it N. And again, it's available in those two brands of Humulin N and Novolin N. And our long-acting products, we've got Levemir, which is insulin detamir. And probably a favorite of a lot of people is Lantus or insulin glargine. U100, it's a U100 product, as most insulins are. Now I want to group these next three together: Lantus, Basaglar, and Toujeo. They are all glargine insulin. Okay, so Lantus is kind of the classic as far as true long-acting analogs go. It just recently came off patent, and so Basaglar or Basaglar, however we want to pronounce it, it's also glargine U100. This you should consider generic Lantus. Again, you can't prescribe it as Lantus and expect them to get Basaglar. You have to actually prescribe for Basaglar if that's what you want them to be put on. But you should think of it as generic Lantus. Now, Toujeo is glargine, but it's U300. So it's 3 times the concentration as Lantus. Again, available in a pen. The pen takes care of the calibration. If you interchange between Lantus and Toujeo, it's a 1-to-1 conversion, basically. And our final product is Tresiba, or insulin degludec. It's available in a U100 or U200 pen. So there are all of our products. We've got some combination products, some mixes. We're going to look at those here in a few minutes. Before we move into those, though, I want to talk a little bit more about a little nomenclature first off, and get my face out of the way here. So some nomenclature to keep in mind. The short and intermediate products, R and N, you could consider those recombinant DNA-derived insulins. No one walks around saying that, but that's how they are produced. They're essentially grown in a lab, whereas the long and rapid insulins, the extremes of those other ones, we call those analogs. They are synthesized in the lab. So they're basically built or constructed, whereas R and N are grown. We also refer to long and rapid acting insulins as maybe basal bolus, where your long actings are basal insulins and your rapid actings are bolus insulins. You could consider regular, the short acting, also a bolus insulin, but you should not consider NPH to be a basal. True basal insulins do not peak. NPH does peak, and we're going to look at those insulin curves here in just a little bit. So there's some nomenclature. I want to start off talking about our classics. So short acting and intermediate, regular and NPH. First off, you ever wonder why regular is called regular insulin? It's because it is just regular old insulin. It is the same structure as what the human body makes. And I guess as a side note, I should say all of these insulins are human-derived insulin nowadays. We no longer have pig or cow insulin that we use. It's all human-derived insulin. But regular is called regular because it is the same regular old insulin that your body produces. NPH, you ever thought about what NPH is? What is the insulin in NPH? Because the name doesn't really tell you. NPH stands for neutral protamine Hagedorn. Hagedorn is just the name of the doctor who created it, Dr. Hagedorn. It's neutral. It has protamine in it. But what is it? Well, the answer there is it is regular insulin. So NPH is just regular insulin that has protamine added to it. When you add protamine to an insulin, it slows down and elongates the effect of that insulin. I'm going to say that again. When you add protamine to an insulin, it slows it down and elongates the effect. So when we look at, we're going to look at a lot of insulin curves here in just a bit. We look at a curve of regular insulin and then look at a curve of NPH. It looks like you just stretched it out and made the regular last a little bit longer. It won't peak quite as high or as quickly, but it does still peak and it lasts longer. So we'll look at those insulin curves here in just a bit. The concept of protamine making the insulin last longer and take longer to affect will play another role here in a minute as we look at some rapid mixed insulins. So I have a point that I want to make about that. All right, so NPH and regular, these are also the only two insulins that we can mix together into the same syringe. That can be convenient because people they might just have to take both of them at breakfast, but they can draw both doses up into the same syringe and give it as one injection instead of two separate injections. Could improve some adherence. Of course, they need to be taught how to do that properly. And there are a couple of rules that you need to know about when mixing regular NPH into the same syringe. So first off, you have to know however many units that they're using, you have to draw the regular insulin into the syringe first, then the NPH. You can think of it like this, the clear before cloudy. So if you picture these two insulins, the vials, the bottles, regular insulin is just a pristine, clear vial of insulin, whereas NPH is cloudy. It looks kind of milky. It's supposed to. That's the protamine in there making it cloudy looking. Any insulin product with protamine is going to be cloudy. So when looking at these, you got your nice clear one that's regular, your cloudy one that's NPH. I told you the rule is stick the syringe into the clear regular insulin vial first and draw up your dose. Then take it and put it in the NPH vial to draw the rest of that dose up into the syringe. If you do it wrong, let's see what the issue is. If I were to draw the NPH first, I would pull my cloudy product into the syringe, and then I would go stick the syringe into the regular insulin vial. And if I excuse me, if I accidentally squirted some of that cloudy NPH into my clear regular vial, I've pretty much just contaminated and ruined that vial of insulin. I just introduced protamine into that vial of R, and a lot of those R insulins are now combining with protamine, and they're not going to behave the right way. If I had contaminated the other way, though, if I had drawn my R up first like I'm supposed to, and then started drawing up my NPH, but accidentally squirted some regular in there, I mean, you don't want that to happen, but if I accidentally introduce a little bit of regular into my NPH product, it's just going to go in there. It's already got regular insulin in it. That's what NPH is. It's just going to go mingle with some more of that protamine that's in there and essentially stay NPH. So I'm not going to ruin my NPH product if I accidentally contaminate it with R. But if I accidentally contaminate the R vial with NPH, it's going to ruin the R vial. So there's the explanation. Always draw the clear before the cloudy, or which would be the regular before the NPH. All right. Looking at the combo products that we have available. Actually, before I talk about that, I want to point out, you saw the little box just go away from under NPH. I pointed out that NPH is just regular insulin with protamine attached to it. Well, I'm going to actually say if that product was created today, we wouldn't have called it NPH. We would call it R-protamine. So think of NPH as R-protamine. All right, next up, let's look at how you have to take these products with food. What's the timing relationship? I want to look at this first from the traditional standpoint of what everyone's been used to over the years. So let's start off with regular insulin. So our short product, regular acting insulin, you're supposed to inject this 30 minutes before meals. Technically, the label will say 30 to 60 minutes before meals, but most everyone tends to say 30 minutes. This is because it just takes that long for that regular insulin to absorb in and get into your blood to where it's going to start peaking the same time your food is getting into your body and needing to get taken care of. So regular insulin needs to be injected 30 minutes before eating the meal. All right, so that's the classic way people have known to use regular insulin for a long, long time. So when rapid insulins came along, they have, there's a kind of the phraseology when talking about the timing refers to a 15-minute window. Well, inappropriately, sometimes people think that it means you're supposed to inject the insulin 15 minutes before eating, because that's the concept with R. You take the insulin a certain amount of time before eating. It's kind of the opposite concept, actually, with rapid insulins. You have to start eating the meal within 15 minutes of the injection. So that means once you give the injection, you can eat immediately. You should start eating within the next 5 to 10 minutes and don't wait any longer than 15 minutes. Rapid insulin is going to peak very quickly. It starts peaking at 15 minutes. I'm sorry, it kicks in 15 minutes. It doesn't peak, but it starts working in 15 minutes. If a person hasn't eaten anything yet at that point, it could put them at risk of a low blood sugar. So I tell my patients, anytime they're on a rapid insulin, get the food ready, have it on the plate in front of them, give your injection, and start eating immediately. That's going to be the best way to do it to decrease the risk of hypoglycemia from poor timing. I find an awful lot of our patients in clinic don't realize this, or they've been told to take it 30 minutes before eating because someone maybe was thinking about regular insulin concepts, or maybe they read that someplace. So regular must be 30 minutes before the meal. Any rapid insulin, do not wait any longer than 15 minutes to start eating once you've injected it. And I would tell the patients to eat immediately after injecting the shot. Now, I do want to say this, FIASP, the faster ASP part, it starts working pretty much immediately after it's injected. People must eat immediately after injecting FIASP, or it's gonna start peaking way quicker than typical Novolog would. and they're going to run into a hypoglycemic risk. Okay, the other timing thing I want to point out is with NPH. When they're taking NPH in the morning, people need to realize that that drug is going to peak in 4 to 6 hours. So they must make sure they're eating a lunchtime, a daytime meal about 5 hours after they inject a morning dose of NPH. It's going to peak. There's nothing they can do to stop it from peaking. Once they inject it, it will peak 4 to 6 hours from now. They better eat lunch on time, or it's going to peak with no food to balance with it, and they're going to get hypoglycemic. Now, in the evening, this may not be as worrisome. I mean, it actually could be more dangerous with an evening dose because it's still going to peak in the middle of the night. But we tend to, going into this knowing that it's common to start off dosing NPH in the evening at a much lower dose, and always make sure there's been a meal in there. So you can work with the dosing to avoid those lows in the middle of the night for a lot of people. Okay. So now I'd like to look at our split mix combo products. I'm going to pick on just using the Novo product. So I could be saying Novolin 7030 or Humulin 7030, either one here, but let's just go with Novo. So a classic, this is a combination basically of regular and NPH in the same product. The insulin product within the vial, it's basically going to function as a combo of regular and NPH. So it's Novolin 7030. What does that 70 and 30 mean? What does it represent? Well, let me put it this way. What does that 70 represent? This is kind of a ratio. Like however many units you use, 70% of it acts as one of these insulins, while 30% acts as the other. So to go ahead and give away the answer, the 70 relates to the NPH. In the United States, the larger number is always the longer acting insulin. Okay, so in Novolin 7030, the 70 represents NPH, the 30 represents regular. So for example, if a patient was injecting 10 units of this combo product, it's as if they just gave themselves 3 units of regular and 7 units of NPH. So and however many units they're injecting, you can always figure that out. However many units they inject, multiply it by 0.7, and that's what the NPH component is. Multiply it by 0.3, that's what the regular component is. So when you're increasing insulin 7030 products, you can make a much more aggressive looking dose increase because it's not as aggressive as it appears. You're only going up on that R dose by 30% of whatever the total dose increase was. So I always do the math on it to look to see, well, just how much have I increased that R when I go up, and make sure I'm getting an appropriate adjustment made. All right, so that's how that's going to behave. The whole point of a split mixed insulin product is convenience. If you have NPH and regular in combo in the same vial, the patient only has to buy that one vial of insulin. You do have to hope that they respond well to a 70-30 ratio balance of the products, and they usually don't. But if they do, great. The way these are dosed is BID at breakfast and dinner time, because that's the way R and N behave. When you draw insulin curves on that here in just a little bit, it'll make a lot of sense why you would dose it just at breakfast and dinner time. R and N at breakfast, R and N again at dinner. Sorry, I'm losing my train of thought here for a second. Yeah, the whole point of the combo is convenience. So giving it twice a day, that's only having to give 2 injections, one at breakfast, one at dinner, instead of all 4 injections of the 2 separate products. That's the concept for any combination product when it comes to insulins. So I want to now share some information about the rapid versions of these insulin products. So we have Novolog Mix 70/30. There's also Humalog mix 75/25, but I want to point out Novo because the numbers are the same as the older Novolin product, 70/30. In fact, these products look identical. The boxes are the same. The only difference is the word mix on Novolog mix 70/30, and that's there to help people differentiate between products. So here's a question. What does that 30 represent in the Novolog mix 70/30 product? It's aspart. So the 30 is again, the faster acting product. So next question then is, what does that 70 represent? I have a lot of people comment right now that it's NPH. And I can see where that answer would come from. On the surface, that makes sense. I've seen people teach it that way, and it's not quite right. This is the concept of NPH, but in rapid form. Remember I told you NPH shouldn't really be called NPH. It's R-protamine. The combos are regular insulin with regular protamine insulin. So the rapid version of this is aspart and aspart protamine. The 70 represents aspart protamine. So this is aspart with protamine attached to it. That product is not available on its own. It only exists in this combo 70/30 product. So this is aspart, a rapid insulin, and a protaminated aspart. So remember what happens when you add protamine to an insulin product. It slows it down and elongates the effect. Now, would this behave the same way as NPH does? You know, it really wouldn't. Regular insulin and aspart insulin, or any rapid, their curves don't look the same. The rapid acting is much shorter. It peaks really quickly and it doesn't hang around very long. If you stretch that out, it doesn't look the same as stretching out a regular insulin. It's not going to behave the same as NPH, but a lot of people believe that it does. So really, there might be a difference in how you use Novolog mix 70/30 or how you interpret blood sugar values versus using Novolin 70/30, the older product. Actually, I want to take a second and draw a couple pictures of this. So let me get out of the PowerPoint for a second. I want to switch over to whiteboard. I'm sure this is not going to look, I'm not going to be able to draw this very well, but bear with me. So here is a line representing this is a timeline through our day. Here's breakfast, here's lunch, here is dinner, here is bedtime. So if I give regular and NPH here at breakfast, my R dose is going to do something like this. It's going to last roughly, its effect is mainly going to last just till about lunchtime. The NPH that I gave at the same time is going to take longer to peak, and it's going to be stretched out more, and it's going to last me until about dinner time. Technically longer, but the ultimate effect, the impact of it has run out by around dinner time. But this is what regular and NPH would look like as far as what the insulin curves do. Now, if I draw another line down here, another timeline through the day, again, here's breakfast, lunch, dinner, and bedtime. Now, if this one is a rapid mix, so this is aspart, here's what that's going to do. I give the aspart at breakfast, it's going to peak very quickly and not hang around. It's going to be in and out, boom, do its job, get done. So if I added protamine to this and stretched that out, it would do something like this. It's not going to peak quite as high or as quickly, and it's going to have this tapering off effect and kind of a tail that goes on out there. It's not quite the same as what NPH does. Similar concept, but not the same effect. So up here with my R and my N, they've both run out by dinner time. So it's time to redose them, give another dose of it right here at dinner. And the R is going to do what like it did that morning, work and last me until bedtime. And the NPH is going to kick in more gradually and kind of hold me through the night to the next morning. Here, now you're on the rapid version of 70/30. You're only supposed to give it just like the other one at breakfast and here at dinner time. So if I gave that at breakfast and it did this, and I give it again at dinner time and it does the same kind of thing with this tailing off effect, if that's how that's going to work, I see a couple problems there. One, if this person eats much of a lunch, they don't have much of a peak here to take care of that meal. Whereas up here and with regular NPH, this NPH peaks around lunchtime and covers their lunch. But down here, this didn't have a peak that lasted into the lunchtime. I guess if someone doesn't eat much of a lunch, then this regimen might work out for them. But if they have a regular lunch, good chance they're going to have a high blood sugar here in the afternoon or right before dinner if they're checking pre-meal blood sugars. And no one, that's what's going to be wrong, is because they don't have enough insulin there to cover a lunchtime. I also look at, so what might you have to do with this product is actually give an additional dose at lunch. So now they're taking 3 doses of the split mix combo at breakfast, lunch, and dinner. And now I also wonder about this tailing off effect. Does it really last a long, long time? Not really. Is there going to be enough of it to last all night? Possible not. They may need a dose of like Lantus or so, basal again here at bedtime to last all day, or all through the night anyway. Well, now you've got this person on a basal and 3 doses of mealtime. They might as well be on Novolog and Lantus instead of the Novolog Mix 70/30 combo product. So I've taken the time to ask drug reps about this, and they've told me that, yeah, this makes sense, that there is some concern about the lunchtime with this product. So honestly, I'm biased a little bit between Novolin 70/30 and Novolog Mix 70/30. I actually prefer the older NPH and regular product because it covers your full day better. It makes more sense to me, whereas the rapid version of the products may not really cover your lunchtime very well. So keep that in mind. If you use it on people and you're supposed to dose it BID, if it works out, great. If it doesn't, they may need better coverage at lunchtime. They may just need to be on a different combo product altogether. All right, hope that makes some sense. I'm going to get out of this and go back to our slides. Okay. Oh, looks like I got to flip back through these again. Okay. All right, so those are all of our products, and a little extra something in there about rapid mixed products. So now that we know all of our products, we know how they behave, and we need to start figuring out how we would go about dosing these products, starting someone on it, and then how to adjust the doses to get them controlled using pattern management. So let's start off looking at how we would do some calculations to start people. So if you're just starting someone out on a full insulin regimen, which honestly I feel like we don't do very much of anymore unless they're a type 1, the first thing you do is calculate their daily insulin expectation, their requirements. And this is not going to be correct. It's an estimate. It's a good place to get us started. And so a common way to do this would be 0.6 units per kilo per day. It's weight-based. You don't have to use 0.6. This is on a scale of like 0.1 to 1, where 0.1 is a really low dose conservative starting point. 1 would be an extremely aggressive starting point. 0.5 is right in the middle. 0.6 is a hair more aggressive than the middle. I find that's where most people tend to start this out, 0.6 units per kilo per day. If you start someone out at more like 0.8, most adults require 0.8 to 1.2 units per kilo per day once they're controlled. If you start them out at 0.8, it's almost like getting to the exact dose too quickly. They're going to have a lot of hypoglycemia problems likely. It would be better to start a little bit under what they're going to require and titrate up into it, get their body used to it, and avoid those hypoglycemia symptoms. So I recommend starting at 0.6 most of the time and doing that calculation. So let's take a 70 kilo person, which is probably not our typical patient, but let's do the math on that one. And we get 42 units per day as kind of our expected daily requirement as a starting point. So we have 42 units per day. Let's first look at NPH and regular if we want to put them on that kind of a regimen. So, and which is probably what you don't do very often. You're probably going to do analogs a lot more often than NPH and regular, but I feel like we still need to know how to do it. There's still going to be those people who can't afford analogs and need to be on NPH and regular. So if we start off with 42 units a day, how do we go about doing this? Well, you want to figure out how much insulin they would need in the morning time and how much they would need in the evening time. So this is kind of an old school way of doing this, but I've never seen a more modern way to do it with NPH and regular. So you give 2/3 of the dose in the morning and 1/3 of the dose in the evening. So if you multiply 42 times 0.66666, you get 28. And the remainder would be 14 in the evening. You're given a bigger dose in the first part of the day because that's where all your food intake is going to happen. You're going to give the lower end dosing on the second half of the day to help avoid hypoglycemia at nighttime when there's not as much eating going on. Now the next step, each one of those, we have to figure out how much of it should be NPH and how much of it should be regular. Same concept. It's going to be 2/3 NPH, 1/3 regular on either one of those. So you take the morning 28, 2/3 of 28 is about 18, 1/3 is R. So there's your, or is 10. So that would, their morning dose, their breakfast time dose then would be 18 of N and 10 of R. The evening dose, we're going to give 14 units in the evening, 2/3 of it. If I'm rounding up, I'll come up with about 10 units of R and 10 units of N and 4 units of R. And this dose is not correct. It's just, it should be a safe place to get things started. Now, I haven't actually done this calculation and started somebody on a regimen like this since 2001. It's been a long time. We just don't tend to do it this way. So many people are on oral agents or non-insulin products. We tend to start off with more basal type insulins first, titrate that, see how we can get control or not, and eventually add mealtime coverages in. So if you were to start a full-on regular and NPH regimen, this could be a way to approach it. I'd honestly still probably start them off with kind of a typical dose of NPH of about 10 to 20 and start with 5 units of regular at those 2 meals of breakfast and dinner as well, and start doing pattern management after that. But this is a way to calculate it. Let's look at analogs. So if we've got analog insulin, this is much simpler. It's, you want to ultimately get people in a 50-50 to 60-40 basal bolus ratio of these insulin products. So if you're doing this to start 50-50 because it's easier math, and this is going to be an inexact calculation anyways, it's a safe place to start things off. Well, 42 units is our total for the day. Half of that's 21. So give them a basal insulin like Lantus, 21 units, and the other 50% is split up into 3 doses of mealtime rapid insulin. So Humalog 7 units TID would fit this one kind of perfectly. Now, another, you can do that calculation. I very rarely ever calculate any of these starting doses. My typical is I start someone on Lantus at 10 to 20 units. And when I start a mealtime insulin, I start at 5 units at meals. That's just the typical way that I would approach it. Let's look on the next slide, because this is more reality. This is what we tend to do. Patients are on non-insulin products already, and we're going to start off with just basal insulin. So if you're adding basal insulin, guidelines would tell us to start off, if you're doing a calculation, 0.1 to 0.2 units per kilo per day. So calculate it based on weight and come up with this dose. Now that almost always tends to come to somewhere between 10 and 20 units. So the guidelines also point out you don't have to do the calculation. You could just standard start 10 or 20 units or somewhere in between. I almost always start 10 units once a day. I just start conservatively and start making adjustments. But if you started at 20, that would not be incorrect. It's in the appropriate range. Heck, 15 would probably make the most sense, because if you actually did start a bolus rapid insulin at the same time, you could do 5 TID and they'd be in a perfect 50-50 balance. So 10 to 20 would be a good way to start a basal. So if they're probably on metformin and maybe a GLP-1, maybe also an SGLT2. They're on some products. They're still not controlled. We decided it's time to add some insulin. We add a basal at one of these lower end doses of 10 to 20. And now we start titrating. I feel like if they're pretty uncontrolled, you can feel comfortable titrating by units of like 5 units of insulin of a basal at a time. And once you start getting close to control, fine tune it with more like 2 to 3 unit adjustments. I want to emphasize, don't overdo it. Don't overdo the titration. I see this done a lot. Really, the concept is you start, they're on all these other products. We add basal insulin, and we're going to titrate it for a while, hoping that that's enough to just kind of smooth their sugars out and get control. I find really it rarely works. Once they need insulin, they usually need a full insulin regimen. Some people, though, can get control with just the basal on top of their other products. So we try it. We start off trying it. Titrate, but there's a point at which you should realize that titration is not going to work and that rapid insulin needs to be added at meal times. So I see a lot of patients who are titrated all the way up to like 80, 90, 100 units of Lantus, so basal insulin. And now someone decides, I guess we'll add some mealtime insulin. It probably should have been done way before then. The guidelines tell us that once we're up to 0.5 units per kilo per day of the basal, it's time to add bolus insulin. So I would calculate it every now and then as you go up on that basal dose, see what it is weight-based. And once you hit 0.5 units per kilo per day, and they're still not controlled, it's time to add mealtime coverage. What I end up seeing is someone will titrate all the way up to like 100 units of Lantus and then add a little 5 units TID of mealtime. And of course, the basal bolus ratio is way out of balance. But you would need to start titrating that mealtime coverage gradually. Don't start them off at a big dose of mealtime that would be in the 50-50 ratio with the basal insulin. You may big time overdo it and hit this person with way too much insulin. They're probably over basaled. You've probably really over titrated the basal insulin. And I think a lot of us have been told titrate the basal insulin until the morning sugars are controlled. That concept is correct if you're on a full insulin regimen. If you're on a full insulin regimen of mealtime plus basal, that's the insulin that would target your morning sugars. It's the basal. If you're only on basal insulin, if you keep titrating, but they have really, really high blood sugars throughout the whole day, there's no big peak of an insulin to really punch that blood sugar level down. And it's by the time they get to, if their sugar is 300 at lunch and 300 at dinner, and you're only on basal insulin there in the evening, there's no peak to really bring those sugars down through the night to get the sugars looking much better by the morning. You can keep going up to a ton of that Lantus, and it's never going to get their mornings controlled if their sugars are just really, really bad throughout the end of the day. Now, so if we're all the way up here at 100 units of Lantus, and now we add in a little bitty dose of mealtime coverage and start titrating it. Keep the Lantus alone. Leave it there. Just go up on the mealtime insulin. Now, what's going to happen as we start going up on it more and more aggressively, we get to bigger doses of it. We may notice that our meal times, the sugars before meals start improving. They start getting a little bit better. So before dinner, they're not as high now. Before bedtime, they're not as high now. Well, now in the evening, the blood sugars aren't so high. Well, that big old dose of Lantus now can have a little better effect. And we see the morning sugars actually start to improve, even though we haven't titrated the basal insulin at all. We've just gotten better control of all the mealtime sugars. So we keep going up on our mealtime. And now we find that we're starting to get some sugars that are almost too low in the morning. Well, now you've got to start backing off of the Lantus. So now as you're going up on the mealtime and down on the Lantus, they're going to kind of meet in the middle at about a 50-50, 60-40 basal bolus ratio. And that's probably where you find you got the patient in good control. If I had hit them with a 50-50 basal bolus ratio when they were way up here at 100 units of Lantus, I would hit them with way too much mealtime coverage, caused a lot of hypoglycemia problems, and could have been dangerous. So try to just not over basal them in the first place. Once you get to 0.5 units per kilo per day, add the mealtime insulin. If you have over basaled them to begin with, though, just start titrating the mealtime and look for when it is time to start backing off of that basal to get them in the right balance. Okay, so once you add bolus insulin, like I said, I would start at 5 units at each meal and start titrating by 2 to 5 units. 2 or 3 would be a conservative increase, 4 or 5 a little more aggressive increase. Like I said, at about a 50-50 basal bolus ratio, that's where you expect to find good control. That's not an absolute rule. Some people will get control at a different ratio, but that's kind of the general expectation. So now let's look at pattern management. We've got them started on a dose, and now we need to figure out if that, let's get into the dose that's going to actually work and get them controlled. We started them off at a safe point. Let's look at pattern management. Now, let's start off looking at NPH and regular. We're going to draw some insulin curves now and look at patterns and figure out how to adjust the insulin doses. So we need to look at 4 times a day. We got breakfast, lunch, dinner, and bedtime. And I'm going to go ahead and add on like breakfast tomorrow on here. I'm looking at this as if the patient is checking pre-meal blood sugars before breakfast, before lunch, before dinner, and bedtime. Okay, pre-meal blood sugars. That's important to realize, pre-meal blood sugars. So in the morning, we're going to give regular and NPH at breakfast time. The R is going to peak like this. It's going to go to work through the morning. By lunchtime, its effect is pretty much finished. The NPH that I give at breakfast is going to peak like this. It's going to peak more around lunchtime and last until about dinner time. Well, now they've both worn out. It's time to redose them and give R and N at dinner time now. R is going to do just like it did that morning, peak after the dinner time meal and last until about bedtime. And the NPH, it's going to peak kind of through the night and last us till the morning. Again, probably have them on a little lower dose there in the evening to avoid risk of hypoglycemia. So there's what the curves look like. Let's look at some patterns now to figure out how to make adjustments. So I've got blood sugars here. This is not just one day. Let's consider this a pattern of several weeks where, and I'm going to just simplify this and make there only be one problem to where we can focus on how to target one particular problem for the day. If their sugars are all high, go up on all 4 of these doses. But if you just had one problem, if lunch is the problem, pre-lunches, breakfast is fine, lunch is high, dinner is fine, bedtime is high, which of these 4 insulins would you increase to attack the high pre-lunch times? Well, I always stop and think, okay, why is the blood sugar high at that point of the day? What caused this problem? If I'm high at lunch, it has nothing to do with lunch. It means my breakfast was not handled well enough. So as remember, it's a pre-meal blood sugar. If it's high right before lunch, it means my sugars from my breakfast are still hanging around. So I need more insulin to manage my breakfast more appropriately in that case. When I have high lunches, breakfast needs to be handled better. Which insulin would have peaked that would handle my breakfast? The morning R. So if the lunches are high, you need to go up on the morning regular insulin. It's going to peak to take care of that breakfast, and its effect is going to run out by lunchtime. Okay, let's look at another situation. So in this case, breakfast look fine, lunch blood sugars look fine, dinners are always high, bedtime is fine. So if my pre-dinner blood sugars are always high, what insulin do I need to adjust to fix that? If the dinner times are high, it's because the lunch wasn't handled well enough. Which insulin would peak to handle my lunchtime meal? That blue curve over the lunch, which is the morning NPH. So if I'm high at dinner time, we need to go up on the morning NPH dose to cover the lunchtime meal better. Okay. What if I'm fine all through the day, but my bedtime numbers are high? If bed is high, it's because dinner wasn't handled well enough. That would have been my evening R dose. So if bedtime is high, go up on the evening R. And if your mornings are high, then we would go up on the only insulin that's really peaking and working through the night, the evening in. The evening in pH would need to go up to correct morning excursions. And that's it. Don't make it any more complex than that. I would target wherever they've got their problems directly. There are times when, yes, you need to fine tune things and be careful. If your numbers are getting close to goal but not quite there, and you go up on something, you may have to back off on a different insulin to avoid causing a low at a different time of the day. So always watch out for those scenarios. But this is the basic way to approach a fixed dose pattern management take on regular and NPH insulins. Now, there's some other things I could go into talking about here, like the Somogy effect and Don phenomenon and those sorts of things. I'll probably save that for a different day, or if you want to ask me about those later on, I'd be glad to get back with you. But look, some people can't be on regular NPH because that elongated peak of NPH can put them at more risk of hypoglycemia. And you back off of the dose and now they're high, and you go up on it again and now they're low. That person's probably a better candidate for analog insulins. So let's look at analog curves. So this would be like our rapid and long-acting products. So same times of the day: breakfast, lunch, dinner, and bedtime. So at breakfast, we're going to give a rapid insulin, any of them, whether it's Humalog, Novolog, or Apidra. And there it is. It's going to go to work very quickly, peak fast, and not hang around very long. So at lunchtime, you give another dose of rapid. At dinner time, you give a third dose of rapid. And then at bedtime, really technically at any time of day, you could give the long-acting basal insulin. We tend to talk about giving it at bedtime a lot. So let's say our long-acting is here at bedtime. It's going to last all day. So if that's Lantus, it's going to last roughly 24 hours. Some other basals last a little bit differently. Your Toujeo will last actually up to 30 hours. Your Tresiba lasts up to 40 hours. You still dose it once a day at about the same time of day, because those longer acting ones, but because they're longer acting, it gives you a little more dosing time-wise flexibility. So Lantus needs to be given at the same time every day because it lasts 24 hours. The others, the last 30 or 40 hours, you got some variability on exactly when that dose should be given. You still tell them to give it at the same time every day, but when they're a little bit late, it's not a big problem with those other products. I should throw this in as a side note as well. Levemir. When you use Levemir at low-end doses, it has to be given BID in order to last throughout the whole day. So the cut point is at 0.4 units per kilo per day. Levemir at doses less than 0.4 units per kilo per day must be dosed BID. Once you get above 0.4 units per kilo per day, you can give it once a day and it will last the whole time. So side note there about Levemir. Okay, back to our insulin curves for analogs. There's the basic curve, and let's look at the pattern management. So same as the last example. If your lunchtime blood sugars pre-meal are the problem, how would we fix that? Well, if I'm high at lunch, it's because my breakfast didn't get managed well enough. So there's not enough insulin at breakfast to fix it. So I need to go up on my rapid at breakfast. If my dinner times are high, it's because lunch didn't get handled well enough. I need to go up on the lunchtime rapid. If bedtime is high, I need more coverage at dinner. I go up on the rapid at dinner time. And if my mornings are high, you're going to go up on the basal, because it's the only insulin that's really focused on hitting. It's the only insulin that would directly hit the morning blood sugars. So here with the full regimen, it's true, you'd go up on the basal insulin until your morning sugars are controlled, because you've got those other peaks to take care of any post-meal excursions. If we're going to compare these curves just a little bit, kind of pros and cons of NPH regular regimens versus analog regimens. I guess a pro to this regimen that we're looking at is that this mimics your body's natural patterns a lot better than NPH irregular. You have this trickle of insulin, and once you eat, you get a peak, and then you still have that trickle of insulin from the pancreas through the day, and you get a peak again after you eat. This mimics your body's natural patterns better. A con, though, is you have to give 4 injections a day, whereas with NPH and regular, you could get away with just 2 shots a day. Another con with this regimen is it's more expensive than NPH and regular. But a pro for this is you have more control over when those peaks are going to happen. With this regimen, you've got more flexibility in your mealtime. If I can't eat lunch on time every day, and I eat lunch here at like 1 or 2 o'clock, well, I just don't give myself my shot until then, and that's when the peak will come. However, with NPH and regular, once I give that NPH dose in the morning, it is going to peak at lunchtime, and there's nothing I can do to stop it. I must eat on time. So keep that in mind with your patients. Some who have erratic eating schedules, NPH could cause some hypoglycemia risks. All right, so those are really the basics. There are plenty of other little nuggets that we could talk about here, but I think we're probably running out of time. So I'd be glad to talk any more about insulin stacking sometime. Insulin stacking, you don't want peaks to compete with each other. 2 stacking insulins that peak at the same time are going to cause a stacking additive effect. That could cause hypoglycemia. Don't do that. Stacking with basal insulins where they don't peak, that's probably fine. Like giving Lantus BID usually is not necessary, but can be done because the overlapping 24-hour doses would just add up to the full dose you were hoping to give. It's like if you're giving Lantus 40 units BID, it's as if you've given 80 units that day. Anyway, those are the basics. I hope that's helpful and useful, and that's going to end things for now. Feel free to contact me if you have any questions. I've added my email address down below at the bottom of the slides, and looking forward to continuing to work with you all moving forward. See you soon.